Welcome to the second day of the Western Surgical 2021 meeting. We have an exciting day. We have, in addition to the original research presentations, we also have a good debate session after lunch. One of the debates will focus on the pros and cons of the USMLE becoming pass-fail, and the other debate will be on laparoscopic common bile duct exploration versus ERCP and lap chole, and we have great presenters for that. Please also remember that we have Dr. Sherry Wren giving our Noni Lowry oration later today. For lunch, there is a great session that has been sponsored by Fortune Law Firm. They actually are also our top sponsor, and we wish to recognize them and thank them. So when you see the Fortune Law Firm booth out there, thank them for their support for the meeting. And then a reminder that tonight is the WSA 2021 President's Reception and Dinner. If you've not already signed up for a table, you can stop at the registration desk right outside. The dinner dance will be located outdoors at the Olive Grove. There's olive trees that you may have seen around there at the 18th tee box. And that's where the dinner will be. Make sure you bring a light jacket because it may get a little chilly when the sun goes down. And the, let's see, the e-poster gallery is also available in the meeting app. So I know that we went through the mini orals fairly quickly, but if you'd like to see some of the data, you can look on the app for that. And then also the business meeting will be held in the general session beginning at 4:40 p.m. So my name is Mike Ujiki. I'm at North Shore University Health System. I'm honored to moderate session number 3, and we'll go ahead and get started. The first paper is by Dr. Kokenauer from the UC Davis on the effect of delays and disruptions in venous thromboembolism prophylaxis in trauma patients.
Thank you, Dr. Ujiki, and thank you to the Western Surgical Association for allowing me to present this paper. I have no disclosures as it pertains to this presentation, and I'm also presenting on behalf of Jessica Folkson, who could not be here today, who should have been presenting this paper. As we all know, if you don't give chemoprophylaxis, there's going to be anywhere from a 10 to 80% rate of VTE. And 45 to 60% of trauma patients receive VTE chemoprophylaxis. Most times the DVT rate is around 1.5% with a PE rate of around 0.6%. And other studies have shown that if there's no chemoprophylaxis given in the first 24 hours, you will see an increase in mortality. Some of the risk factors, as we all know, especially in trauma patients, male, obese, older age, inflammatory conditions or cancer, sepsis, immobility, lower extremity injuries. But it's a balance because obviously trauma patients are going to bleed, and you don't want to have them bleed and be on chemoprophylaxis. So why are there interruptions? It can be anywhere that the patient may not be present at the time they would normally get their dose. They may refuse to get poked in the abdomen. There may be concern for continued hemorrhage. Their hemoglobin's still dropping. They may be thought of as, oh, they should be able to be up and walking. They may have a pain block planned, and the anesthesiologist who's doing the block doesn't want to have them on any kind of DVT prophylaxis. Or another one that's common in our institution, on call to the OR, which may be for several days in a row if they can't get into the operating room. So what we know is that trauma patients are at high risk. If you scan them, you will find more DVTs. And trauma patients do miss doses of prescribed VTE chemoprophylaxis. We know that there are contraindications to VTE chemoprophylaxis. But what we don't know is what's the rate of the VTE in our trauma population, and what's the impact of missing individual doses of VTE chemoprophylaxis on the risk of developing either a DVT or a PE. So our question was, what was the difference in VTE chemoprophylaxis rates between patients that did develop some form of VTE, venous thromboembolism, and those that did not develop a symptomatic VTE? So this was a retrospective single-center case control study, trauma patients that were admitted between January of 2015 and November of 2020. We got the information about them from the trauma registry. They had to be hospitalized at least 2 days, and they had to have no significant head injury, and they were either 18 or older. Exclusions were typical: pregnant, prisoners, if they had a VTE found on admission, or they had a diagnosis of HIT, heparin-induced thrombocytopenia. So we matched those that had developed a VTE to non-VTE patients in a 1-to-3 ratio. They were matched on their decade of life and their injury severity score. Additional risk factors that were collected: the frequency of surgical intervention, as well as whether or not they had a lower extremity fracture, and their weight. VTE chemoprophylaxis was assessed every day up to 14 days or until they were discharged, or they had identification of some form of VTE complication. And then it was decided what the proportion of doses given versus what was anticipated for the day. For example, if they were on a BID dosing schedule and they only received one, then it would be at 0.5. Our assumptions were that patients were on the correct VTE chemoprophylaxis, and if no medication was ever ordered, we assumed that they should have been on enoxaparin 30 milligrams BID, which is our institutional guideline. If medication was ordered later, we therefore applied it to days with none ordered, and all unfractionated heparin IV infusions were treated as a Q8-hour dosing regimen. Our primary outcome was the proportion of VTE chemoprophylaxis doses given over the first 14 days of hospitalization. Secondary endpoints included the ICU length of stay, hospital length of stay, time to the first dose VTE chemoprophylaxis, and in-house mortality. Our statistics, proportional data was using chi-squared, categorical data was descriptive statistics, normally distributed numerical data students t-test, and we did a Cox proportional hazard. We screened nearly 19,000 patients. There were 7,435 that met inclusion criteria. There were 63 total patients with a VTE, but 19 of those were excluded, whether most because they had a VTE on arrival, they were prisoners, or they had HIT. So we had 44 that were included. There were 7,372 that did not have VTE, and we used those for the matching pool. And of the non-VTE matched patients, we had 132. 7 of those were excluded, so we had a total of 125 that were included for matching. Baseline characteristics: age was not particularly different, nor was gender and our ethnicity. Injury severity score, again, nearly the same. It was in weight, where the VTE patients had a significantly higher weight over non-VTE patients. Their lower extremity fractures were more, with 54.5% versus 40%, and they also had a higher number of operations, 2.5 versus 1.3. And interestingly, the time to first dose was slightly higher in those with VTE patients versus the non-VTE patients at just over 2 days, 56 versus 50.5, which is similar to what is found in the literature. Interestingly, nearly 30% of VTE patients never had VTE chemoprophylaxis started versus only 17%. And most were considered appropriate of the larger, there was 22.7 in VTE versus 38.4. And we had a higher number with dose too low versus non-VTE patients at 17.6. And this was our primary outcome. And as you can see, this is the percentage of VTE chemoprophylaxis doses received. And for non-VTE patients, which is seen in this upper line with the open circles, 59% of chemoprophylaxis doses were given versus only 49% in the VTE cohort. Secondary outcomes, VTE patients had a higher length of stay in the ICU, definitely a higher hospital length of stay at nearly twice the number of days, and there was a larger number of non-VTE patients at discharge. Using the Cox proportional hazard model, which was adjusted for age, ISS, lower extremity fracture, and number of operations, for every 1% increase in VTE chemoprophylaxis, there was a 7% decrease in hazard of VTE. For every 1 kilogram increase in weight, there was a 1.7% increase in hazard of VTE. Most reasons for delays and disruptions was either a hemoglobin decrease or operations. There were a number of strengths and limitations mainly that was retrospective and observational. Matching does lead to some inherent bias, and we did not prospectively screen for VTE, so we really can't tell you what the rate of VTE in our population was. So in conclusion, patients developing VTE are more likely to have had delays and disruptions in their VTE chemoprophylaxis. There was approximately 10% fewer VTE chemoprophylaxis doses given to patients who developed a VTE. So the difference in VTE chemoprophylaxis remains significant even after controlling for age, ISS, lower extremity fractures, and number of operations. Obesity and subtherapeutic VTE chemoprophylaxis dosing appear to be associated with a higher rate of VTE. So in summary, missing even that one dose can make a difference. So our future directions, we need to look for ways of reducing the time with no chemoprophylaxis. They're trying to convince our orthopedic colleagues to let them go on Lovenox, and also to make sure we're optimizing our VTE chemoprophylaxis dosing. Thank you.
The discussant for this paper, Dr. Eric Lee from Cedars-Sinai Medical Center, could not be here, so we have the questions here, so I'll read them to you. Venous thromboembolism after trauma is a potentially preventable complication that can be lethal. Recent recommendations focus on earlier, uninterrupted, and higher doses of enoxaparin. Dr. Kokenauer and her colleagues are to be congratulated on a well-performed analysis that supports these recommendations by delineating how delays and disruptions in chemoprophylaxis are associated with VTE after trauma. The methodology for the analysis is unique. TBI was an exclusion. Patients receiving therapeutic anticoagulation like a heparin drip or Coumadin were included. Chemoprophylaxis dose was based upon the presence of lower extremity fracture and weight. Patients with a known VTE were compared to those without thorough propensity matching using decade of life and ISS. The primary outcome was the adherence to dosing per the institution's VTE guidelines for the first 14 days of admission. The retrospective case control comparison matched 44 patients with a VTE to 125 without. Delays and disruptions of chemoprophylaxis were associated with an increased risk of VTE. Could you please address the following questions? Number one, how many patients were started on enoxaparin 40 milligrams Q12 or higher, as is recommended for most patients by the Western Trauma Association guidelines? Were doses adjusted after the initial dose? Similarly, how many patients received heparin and Coumadin, and would your results change if these patients were excluded? Number two, could you please provide additional details on what was defined as a DVT? For example, were clots in the calf included? What about upper extremity clots or those identified only on CT? Similarly, did any patient have a pulmonary embolism? And then third and last, increasingly trauma patients who have an epidural in place receive lower than the recommended doses of chemoprophylaxis. What percentage of your patients had an epidural in place, and did the epidural alter the dosing of chemoprophylaxis or alter the rate of VTE? Thank you for allowing me the privilege to discuss the manuscript.
I would like to thank Dr. Lay for his very thoughtful questions. And I'm not sure if you can pull up my slides again, but if not, that's okay. So how many patients were started on enoxaparin 40 milligrams BID or higher? We only had 5 that were that had received that dose or higher in the non-VTE group, and then 2 in the VTE group. Of those that were adjusted, there were let's go all the way down. Okay, it's not moving, so that's okay. And if the doses were adjusted, of the non-VTE group, there were 26 that were changed and 14 in the VTE that were changed. And these changes could be anywhere from decreasing to increasing or even changing the type of medication, depending on, most likely because of what was happening with their renal function. And how many had a heparin, drip, and Coumadin? Of the non-VTE group, there was, of the non-VTE group, there were 12 had therapeutic heparin drips, 2 had prophylactic heparin drips, and then in the VTE group, 5 were started on therapeutic heparin and changed to, and a couple of those were changed to enoxaparin prophylaxis. We did not take those into consideration into our analysis. We did not take them out. The proportion was similar, and so it's something that we could look at in the future. There were 3 patients that came in on warfarin, 2 in the VTE group, 1 in the non-VTE group, and all had coverage with other agents because they had been reversed when they first came in. The second question was, essentially what was defined as a VTE, and basically, if the patient was treated for either a PE or DVT, they were included in this analysis. Our group does not necessarily treat for a lower extremity when it's in like the soleus veins. We also are mixed on whether or not we treat for subsegmental PEs. Majority of patients did have PEs. There were 22 PEs only. There were 7 patients that had both PE and DVT. And then what percentage of patients had an epidural? We did not specifically look at if they had an epidural or another block. And this occasionally comes into play because if they're either going to put in an epidural or they're going to take out the epidural, they usually want the Lovenox held. Normally, patients routinely receive 40 milligrams every day if an epidural is in place. So,
I think that was it.
I think
Thank
that
you.
was it.
We have a question from Dr. Brazel.
Chris, there were 2 things that struck me with your data. One was the significant difference in the secondary outcomes between the 2 groups, and I'm wondering if, I know it was, your data were matched on ISS, but is the VTE really the difference in that much length of stay, and does that really account for the mortality difference? And my second question is, even in the patients that did not have a VTE, there was only 59% compliance, it looked like, and I just wondered what your thoughts are about being able to increase the compliance with the ordered dose.
So I'll start with that second question first. We have difficulty getting into our operating room. And it's not unusual for people to hold DVT prophylaxis when people are thought to be going to the OR. And if you have someone waiting to go to the OR and then they don't go, they're off for that day, or they may only get 1 dose. They are on call for several days in a row, and that's one of our biggest things. Some of our orthopods will actually let us continue our Lovenox. And so I think we have to really get that word out to our residents and trainees and attendings to not stop the Lovenox when we're waiting for patients to go to the OR. I think that's going to make the biggest difference. The things like continued drop in hemoglobin, that's not something we can really deal with. That's not going to change things. And then I think your first question was,
Difference in the secondary outcomes being totally
I'm not
accounted
really
for by
sure
the
what that
VTE.
is from, and that was one of the reasons we did try to adjust using ISS, but I can't imagine that it's completely attributable to just the VTE diagnosis. And so that's something that's going to take some more work and look at to see why was there a difference. And then length of stay is always a bad outcome parameter anyway, especially if you have a non-resource population, because they don't, especially with lower extremity fractures, they may stay there forever because they have no place to go.
Okay, thank you very much.
Thank you.
Our next talk is by Dr. Ching-Wei Zing from MD Anderson Cancer Center on prospective implementation of standardized post-hepatectomy care pathways to reduce opioid prescription volumes after inpatient surgery.
I want to thank the Western Surgical for this opportunity to share our research, and I want to acknowledge our T32 research resident, Tim DePuri, who's with a family event right now. So there have been about 500,000 American deaths been attributed to the opioid epidemic over the past 20 years. And obviously, we're not the ones prescribing heroin and fentanyl to outpatients, but a surgical episode is often a patient's initial significant exposure to opioids. So one strategy to reduce opioid utilization during surgery is standardizing the opioid prescribing via enhanced recovery pathways, which is pretty commonplace nowadays. We have previously introduced the idea of 4 pillars, which I'll discuss, or targets of postoperative opioid reduction. And in September 2019, we started a post-hepatectomy care pathway. The initial reason for it was just to reduce our length of stay from a median of 5 down to 4, and that was our initial goal. And the second was to reduce the variation of care to help our trainees and APPs so that it wouldn't be just trying to read the minds of the faculty. So we saw an opportunity to reduce our discharge opioid prescriptions and the dissemination of opioids into the community. So our hypothesis was that the postoperative opioid needs and dissemination would be reduced with using these pathways for care. These are the 4 pillars I want to talk about. In the black curve, you can see what I call just standard operating procedure, where if you don't do anything, this is what will happen. You have the initial high peak, and you wean down to whatever it may be, and you discharge at this point in time with whatever amount of opioids you may need, and they may eventually come off opioids, maybe. So pillar 1 is to educate providers and patients about realistic goals for postoperative pain control and ambulation. Pillar number 2 is to limit the initial peak in hyperalgesia and that initial amount from the runaway mathematics of IV PCA use in that first 24 hours. Pillar number 3 is to accelerate the weaning process to 0 or near 0. And you can see I drew in the green here an inflection point to really purposefully try to drive it down as low as possible using multimodal anesthesia that we'll talk about. And then finally, your bookend for care is at discharge. As you know, provider bias can sneak in here, where you may try to be quote unquote nicer to the patient and help them out by giving them extra opioids when in fact you're not helping them at all. So standardizing your discharge metrics will be the way to go here, with the goal eventually to reduce persistent use for the individual patient and to avoid diversion into the community, which is the real problem in the United States. So these are methods for our study. It's a retrospective cohort design looking at 2 periods of time with consecutive hepatectomy patients. These are patients who stayed more than 48 hours and were discharged by our team, not by, say, the colorectal team. The intervention was an opioid reduction education program we did over a course of 1 year in 2018 to the summer of 2019, including APPs, trainees, and faculty. And we created the risk-stratified post-hepatectomy pathways in August of 2019 to start. So we have 2 cohorts. One is just from our EPIC rollout in March of 2016 for about 1.5 years, and then we have our post cohort, which is the initial 100 patients on this pathway. The primary outcome was the discharge oral morphine equivalence, but the secondary outcomes we want to look at was how well we weaned to the last 24 hours of opioid use, how many % of patients had 0 opioids at discharge, and what % of patients were compliant with what we call the 5X multiplier, which I'll explain. So preoperatively, we do counseling with opioid expectations, which I have to say that we used to skip over because you focus on complications from your liver resection and bile leaks, things like that. You're not really focusing on your opioid needs, so it's really important to give a handout about what you're going to be actually getting in the hospital, so we give a handout ahead of time. Right before surgery, of course, anesthesia is given the opportunity to give pre-medications. It can be tramadol or celecoxib, sometimes a gabapentinoid. And we use blocks 100% of the time, sometimes epidurals, and I'll call that a regional anesthesia. The first 24 hours really is the most important, again, to limit that runaway mathematics of using the IV PCA. Before we limited, you see here, We limit it now to 0.1 milligrams Q10 minutes. Before that, it was up to the trainee who was putting the patient in the recovery room. It could be 0.1, 0.2, 0.3, 0.4 Q10 minutes, and the mathematics really runs away pretty quickly. By the next morning, you could use 20 milligrams of Dilaudid if you're not careful. The non-opioid bundle oftentimes is, I think everybody uses this, but sometimes not used till post-op day 1 or post-op day 2, but it's used immediately because these are liver resections, and even most GI patients can take oral medication. So acetaminophen, Robaxin, which is a muscle relaxer, and celecoxib at a very low dose is used automatically. Then we talk about the inpatient stay, and that can vary. Depends on how many days you're in the hospital, 1, 2, 3, 4, 5 days, that period of time. You really want to be purposeful about weaning the IV medications and getting them down to PO, because PO medications are smoother coverage, as you know, and don't add up to as many oral morphine equivalents. So that's the real important part, not to be leaving that PCA longer. And we even repeat the anesthetic block if necessary. We see a patient who's really struggling, we'll do rescue blocks. I have to point out here that this pillar number 3 is a problem that we have in the United States. If you talk to our colleagues in Asia and Europe, where the length of stay for these HPV operations can be 7 to 14 days, they laugh at us and wonder why we use morphine. Well, it's because they're in the hospital for 14 days, and so they're not on anything when they're discharged from the hospital. We're hurting ourselves in the sense that we put pressure on ourselves to discharge these patients by post-op day 3, post-op day 2, and so really you have to be purposeful about weaning the opioids while they're in the hospital. And finally, at discharge, we use the 5X multiplier, and what that simply means is you look at the last 24 hours of opioid use. So you use 2 pills, then you multiply that by 5, and give 10 pills for discharge. And then we do a follow-up about 24 to 72 hours, 1 business day later, to make sure that things are going okay, that they picked up their prescriptions, that sort of thing. So these are our results. The first thing is to look at the results of the first 3 pillars that lead to the last 24 hours of opioid needs. And you can see that we reduced it from 20 milligrams oral morphine equivalents to 10, and by translation that means 4 tablets of tramadol, for example, down to 2 tablets. And that's from that aggressive weaning program and the education program. Then we use the 5X multiplier. The thing to point out about the 5X multiplier is if you're down to 0 already, 5 times 0, of course, would be 0. So you don't give 30 pills out the door if you're already down to 0. So you look at the results here. The final discharge prescription, the median was 200 milligrams in the pre-cohort, and in the post-cohort is down to 50 milligrams median. So it's down from 40 to 10, as you can see. So pretty dramatic, 75% reduction. And we didn't change our practice, obviously, in this very short amount of time in this modern cohort. So you can see here the percentage of patients who got the 5X multiplier increased dramatically. While we didn't require it, this was educated to all our discharge providers, whether it's a weekday or weekend, whether it's a trainee or APPs. And you can see this is probably one of the major reasons why at the discharge we were able to cap the amount of prescriptions given out. And the amount of people who are opioid-free after a hepatectomy, which is thought to be a painful operation, dramatically increased, and again, it's because they're on multimodal anesthetic analgesia as well. It's not like they're given nothing at all at discharge. I want to show this graph again because I want you this time to focus not on the median, which is too easy to look at, but rather look at the interquartile range. You can see that in the pre and the post, it was a pretty wide variability in care that we were giving to these patients. And here it's a much narrower where, in fact, the lower bar of the interquartile range is down to 0. Same thing in our discharge prescriptions, that the interquartile range lower bar is down to 0. The other thing to point out here is if you look at the bottom here in our pre-cohort, the last 24 hours, there's a decent number of people who are down to 0 opioids in their last 24 hours. That's without us trying back then. And yet, the prescription they were given, they were still giving something up here. They were still given something even though they didn't really need it. And so the key here in the post-cohort is that if they're down to 0, they stay at 0. So in summary, the implementation of a post-hepatectomy care pathway, whose primary purpose was to reduce length of stay, was secondarily beneficial in accelerating inpatient opioid weaning by 50% in the last 24 hours, and also reduced the final discharge opioid volume using that 5X multiplier by 75%. And importantly, it reduced variability in care, which helped expectations for our trainees and APPs, and also helped the patient with understanding what their post-op care would be before they even had their surgery. So in conclusion, this no-cost reproducible pathway can be used in all abdominal operations, as we've had done in our department, to decrease variation in opioid dosing while prioritizing patient-centric needs. Thank you.
Excellent work. This paper will be discussed by Dr. Amanda Arrington from Houston Methodist Hospital.
I would like to thank the Western Surgical for asking me to discuss this paper, and for the authors for providing me the manuscript early. Dr. Zhang and colleagues at MD Anderson implemented risk-stratified post-hepatectomy opioid pathways in 2019. The opioid epidemic is widespread, and efforts on surgeons' parts to decrease discharge narcotic prescriptions safely are absolutely essential. I do have the following questions for Dr. Zhang. First, you mentioned the 5-time multiplier in your manuscript and presentation. Is this now a validated tool to determine the number of pills to prescribe at the time of discharge? Does this take into account the amount of IV narcotic, tramadol, Robaxin, if any, during the last 24 hours? Secondly, has a reduction in narcotic administration led to more patient calls to the clinic for pain reasons? And if so, have you seen a decrease in patient satisfaction indicators? We also employ a multimodal pathway for our surgical oncology patients at our own institution. As you know, some of the multimodals are withheld or dose reduced in the setting of renal impairment or liver resection, particularly Celebrex. And there's other side effects of note with gabapentin. How much was the multimodal altered, or you not having, being able to provide standard doses? And finally, only 59% of your post-implementation patients received the 5-time multiplier dose. I would have actually thought this was much higher. So what was the difference in that 41%? Was it more of a resident fellow education matter, or were these patients different or just required more medication in this setting? Once again, thank you for the opportunity.
Thanks so much, Dr. Arrington. I'll start with that last question. So it's not 100% compliance because it's not a hard stop in EPIC, and perhaps we could do that in the future. And so there are some non-compliance issues where sometimes it's forgotten or whatnot, and so that's happened before, where even people with zero opioid needs are still given some prescriptions, so it does sneak through. But it's a dramatic difference from 10% up to 60%. Going back to the top, the 5X multiplier is something we came up with in 2017 to 18 range because the CDC at that point in time had recommended giving a 5-day prescription out the door at most, but that's a very nebulous concept. And also the Dartmouth group had talked about looking at your last 24 hours and predicting how much you actually use post-discharge when you get home. So based on that, we just chose the number 5 because it's very easy to multiply and you don't have to have some kind of calculator in your hand to figure things out. It does include IV counts, so if you give a small little bolus dose in their last 24 hours, that does get counted in there. But that's pretty rare, and the goal is hopefully you should be off IV stuff in that last 24 hours anyway, right before. Did it worsen patient satisfaction? Based on our refill rates, it did not change our overall refill rates, and in fact, we looked at this, that our refill rates were in a 10 to 15% range. You can imagine this is an individual decision for practices. What do you think is an appropriate amount? You probably can't drive it down to 0 refill rate no matter how high you go in opioids, nor would you want something where you get a 50% refill rate. That would be way too high. So we noticed 2 things. It was a pretty flat in terms of our study, in terms of validating it, in a separate study that we published in a 10-15% range. But the other thing we've noticed that we're about to publish is that not only did the 5X lead to less refills versus those who got super 5X, above 5X, but the refill size was smaller, and I called it the soda fountain effect, in that if you give me a 36-ounce cup, I'm going to get a 36-ounce refill. If you give me a small cup, all I get is a small refill. So it trains the provider who answers the phone to give, oh, they only got 5? I'll give you 5 more. If I got 30, then I'm going to give you 30 more naturally. So I think that's helped. And in terms of patient satisfaction, we do have that 24 to 72-hour next business day phone call to capture issues where we made a mistake in whatever way. And we did look at people who got 0 opioids, and 7% of people do end up within 30 days getting an opioid prescription. So 1 out of 14, so 13 out of 14 still remain without opioids. Thank you.
This paper is open for discussion. Dr. Scoggins?
Hi, Chuck Scoggins, Louisville. Thanks for taking the reins of making this a science. You know, we all are trying to do ERAS pathways, but your group has made this a science, and we're still learning from you. My question for you is, how confident are you that patients aren't being discharged from MD Anderson and going back to Austin or somewhere and then getting their family practice doc to calling them some Norcos or something? We find that to be very common in Kentucky. We have a method for capturing that because our state requires us to register all narcotic scripts into a computer program, and we're required to check it before writing a new one. How confident are you that patients aren't doing that?
Yeah, that's a good question. I was inspired to do this because my first job was at University of Kentucky, as you know, and we had a lot of patients from Appalachia, and a lot of people had a lot of opioid use outside of the hospital. And so I think I'm relatively confident about that because most of our patients come to us for everything, including blood pressure pill refills. And so I would think opioids are going to come to us. And I think most primary care doctors usually are afraid to prescribe anything in the post-operative period and kind of step on toes into surgeons. But in Texas as well, we do have electronic thing to check opioid use.
Rick Thirlby from Seattle. I have a question regarding your incorporation of the multimodal non-narcotics. By that I mean Tylenol, NSAIDs, and gabapentin. I couldn't tell from your manuscript if that was scheduled or PRN. I think it's very important to emphasize that these discharge medications should be scheduled. Scheduled NSAIDs, scheduled Tylenol, scheduled gabapentin, likewise in the hospital the same way. I think there's too much history of having PRN, aspirin.
Right. No, you're 100% right. So it's scheduled, starting post-op day 0 in the PACU. Just for making it easier, we do sometimes give it IV Tylenol, which I know is a controversial thing because it's expensive just for 1 or 2 doses just to get it in, and then Robaxin is IV. Going back to Dr. Arrington's question about how often we use this, 100% of patients, of these liver patients, get Tylenol. They may not get it in the first day, I have to admit, when they get a 60% or more resection, but we usually start it by the next day when their bilirubin is peaked. Celebrex, about 75% of patients will finish the Celebrex. Some small amount may not if they have CKD at baseline, but we're using a baby dose, 100 milligrams BID. It's a very small dose that we're using. And Robaxin, more than 90%. People are worried about Robaxin causing somnolence. Well, it doesn't mean that you have to put everyone in the same dose. If it's a petite, older patient, we may give 250 milligrams Q8. If there's a larger man, we may give 750 Q6. So you can adjust that.
We'll go here and then here.
Michael Egger, University of Louisville, Chingway, great study. Thank you very much for presenting it. My question is, how many of these patients were not opioid naive before surgery? So
Sure.
We've looked and found about 1/3 of our patients with major GI surgery come to us on opioids. So were you able to implement this on those patients who are already on opioids?
Yeah, great question. We looked at all our HBV patients, including pancreas, and the most common reason they have some opioids because at the very beginning they're assigned this concept of neoplastic pain and they're given a prescription from their medical oncologist. And so 50% of people have it on their chart. But in reality, if you really ask them, they're only using it kind of here and there, or if they're kind of anxious the night before surgery. So those patients can be completely weaned off opioids. Only about 5% of our patients are true chronic opioid users using the fentanyl patches of the world, the OxyContins, things, that sort of thing. You're not going to be able to get those people off, but the best you can do is actually not escalate. To me, it's a victory if I can do their operation, not escalate beyond what they're on at baseline.
Collins, Los Angeles, thank you very much for highlighting this important topic. CDC estimates that last year 70,000 people died in the U.S. of opioid overdoses. Surgeons are a little bit like Galapagos finches. We're descended from a common ancestor, and then we sort of evolve in our separate microenvironments. You alluded to the idea that you were getting all your practitioners in line. We've seen sabotage from nursing and pharmacy, and they're not totally on board with the idea of polypharmacy, multimodal prescribing. And so they'll say, if you have mild pain, take this. If you have moderate pain, take that. And the Joint Commission is reinforcing that. How are you approaching that at MD Anderson?
That's a good question. Yeah, we actually have a pain task force whose only purpose is not to reduce the amount of pain medicine, but rather to activate pain consults, which is exactly what I don't want. And rather, so the main thing is to educate the nurses on the floor and to clean up the MAR. So that's the thing. I always, when I look through the chart, and if the MAR is still saying IV pain medicine, they're post-op day 3, I ask the fellows to clean that off. That shouldn't even be on it, because that gives you the option to choose it. If they haven't used the IV dose of dilaudid, why in the world is it still hanging on the MAR? So a lot of that is on us to try to clean up the MAR and only offer oral medications. Our next door neighbors at UT Memorial Hermann, the UT McGovern Medical School, the big trauma center in Houston, don't use any IV PCA for their traumas, even rib fractures. If they can do that, then I can do elective surgery without using too much PCA.
Thank you very much. Our next paper will be presented by Judy-Ann Ramskol. Dr. Julie-Ann Ramskol will do partial biopsy techniques influence survival in melanoma, matched pair analysis of MSLT 1 and 2. She's from St. John's Cancer Institute at Providence, St. John's.
Thank you. Okay. Just like, okay. Well, thanks again for the opportunity to present today. I have no disclosures. So in melanoma, the traditional teaching for the biopsy of melanotic lesions is an excisional biopsy. And the current NCCN guidelines support this by saying you need an excisional biopsy with narrow margins of 1 to 3 millimeters and condoning partial biopsy techniques only when sampling sensitive areas such as the digits or when sampling large lesions. The emphasis on excisional biopsy over other techniques is due to a decreased chance of misdiagnosis, and also that residual tumor leads to inaccurate assessment of the Breslow depth. And also the importance of Breslow depth and moreover T-stage in the prognosis and treatment in melanoma. And this is seen here. This is from the seminal paper introducing the new AJCC 8 guidelines for melanoma, showing that there is poorer prognosis with increasing T-stage. And here you can see T4B in this pink line here. Yet, partial biopsy techniques are still commonly used, mostly because presumably they're easier to perform and quicker, making them more time and cost efficient. When you look at partial biopsy techniques, there is an increased risk of T upstaging, and this is due to the residual tumor not being accounted for in the initial T stage. However, again, there is an increasing use of partial biopsy techniques being used, and this is shown in recent studies. And again, several recent retrospective studies suggest that the use of partial biopsy techniques does not have an adverse effect on recurrence and survival outcomes. So we kind of looked at these observations to come up with our question, which is poor survival associated with the presence of residual melanoma in a wide local excision specimen after a diagnosis via a partial biopsy technique? In order to answer our question, we looked at MSLT1 and MSLT2, which were two large, multi-center randomized trials looking at sentinel lymph node biopsy, looking at sentinel node status in melanoma. We looked for patients who underwent a partial biopsy technique. This was punch, incisional, or shave biopsy. And patients included were diagnosed from 1994 to 2014, which was prior to the advent of modern systemic therapy. We looked at all their pathology reports and reviewed them to determine the presence or absence of residual disease in the wide local excision. We made two groups. Group 1 were patients that had no residual disease in their wide local excision, and Group 2 had residual disease in their wide local excision. And when we looked at our initial grouping, we saw that there was a difference between groups, and this is seen here in this orange highlight. There were differences in groups between primary site, Breslow thickness, and sentinel lymph node status. Oh, I've stopped clicking. Help? Okay. Can we go back one? Sorry. Right click. Okay. There you go. So what we did find was that the majority of patients undergoing a partial biopsy technique did have positive biopsy margins, and this is shown here. But interestingly, even with the patients that had no residual tumor in their wide local excision, they also had positive biopsy margins. Nevertheless, we found that T upstaging was uncommon. So in the patients that had residual tumor in the wide local excision, 98.5% had no change in their T stage after their definitive wide local excision. So based on the fact that our two groups after initial grouping were different, we decided to do our analysis using a match pair. We matched our groups based on the clinical pathological factors that are known to affect outcomes in melanoma. So this is sex, age at diagnosis, primary site, Breslow depth, ulceration, and sentinel lymph node positivity. We grouped them in a 1-to-1 ratio, and the total number of patients included in our study is 514. We had a median follow-up of 70 months. After matching, we confirmed successful matching using a chi-square test. And of note, in MSLT1 and 2, patients that had thinner non-ulcerated melanomas were excluded from those studies, and so we have a preferential inclusion of thicker tumors in our study. We also looked at the clinical factors of time from biopsy to surgery in weeks, as well as patients that underwent completion lymph node dissection after being found to have a positive sentinel node, and we found that there was no difference between these in our two groups. The primary endpoints for our study were disease-free survival, distant disease-free survival, and melanoma-specific survival. We also looked at subgroup analysis of melanoma-specific survival for, again, the clinical pathologic factors that are known to affect outcomes in melanoma. So when we looked at disease-free survival, we see our Kaplan-Meier curve here. For 10-year disease-free survival, there was no difference between patients with no residual melanoma in their wide local excision versus patients that had residual melanoma in their wide local excision. That's shown in red. Similarly, with distant disease-free survival, there was no difference between patients that had no residual melanoma in their wide local excision at 68.7%, shown in blue, versus 65.3%, shown in red. And then finally, melanoma-specific survival at 10 years was 73.6% for patients with no residual melanoma in their wide local excision versus 73.9% with residual melanoma in their wide local excision. We also did subgroup analysis, as I mentioned, of the clinical pathologic factors known to influence outcomes, and we didn't see a difference in the subgroups based on older and younger patients, thinner and thicker melanomas, ulceration, or sentinel lymph node status. What we did see was a difference in patients based on the subgroup of primary site, and found that melanoma-specific survival was different in patients with truncal melanomas and extremity melanomas. Here's our Kaplan-Meier for extremity melanoma. We see that 10-year melanoma-specific survival is worse in patients with residual tumor in their wide local excision, which is seen here in red with a p-value of 0.0275. However, interestingly, the opposite was true in truncal melanomas. So our 10-year melanoma-specific survival for patients that had no residual melanoma in their wide local excision, which is seen here in blue, was 59.4% versus 80.4% for patients that did have a residual melanoma in the wide local excision, and the p-value was 0.0396. So we were surprised by this, but the results were actually corroborated on both multivariable and univariable analysis. So here on the primary side of extremity in the top row, you can see that the hazard, if you had residual tumor in your wide local excision, hazard ratio for death was 2.12. This was significant. And then on truncal melanomas, the opposite was true. So you see that the hazard ratio for death with residual melanoma in the wide local excision was 0.52. And this again was statistically significant. So then the question becomes, why would survival be impacted positively in truncal melanoma patients if they have residual tumor in their wide local excision? We took a look at our data again, and we saw, again, we matched the data, so there's not a difference in the major clinical pathologic factors. There was also no difference, as we saw, in completion lymph node dissection after positive node or time to surgery. We did find in looking through the literature that a similar observation was seen in a study from 2007 where phenomenon biopsy-induced tumor regression was described as and attributed to why this was happening. And this has been described in non-melanoma skin cancers. And they look at molecular changes in the tumor microenvironment and wound healing after biopsy to kind of explain the findings. And it might just be, the extraordinary immunogenicity that's known to be associated with melanoma that can help describe our findings as well. Of course, our study has limitations. It's retrospective. There is a selection bias in that we couldn't control the factors in which the type of biopsy for diagnosis was chosen. We had a preferential inclusion of thicker tumors, and this was a multi-center study. And while about 66% of our patients had their slides reviewed by a trial pathologist, that's the majority, but not all of the slides. But it does add to a growing body of work that's studying the impact of incomplete biopsy techniques on patient outcomes. It has some of the longest follow-up, and it has the largest cohort of thicker tumors. So in conclusion, melanoma patients who undergo partial biopsy techniques and have residual tumor in the wide local excision specimen do not have a poorer prognosis. And this was seen in disease-free survival, distant disease-free survival, and melanoma-specific survival. T upstaging, which is one of the reasons noted for why excisional biopsy is superior to other types of biopsies, was actually seen in very few patients. And in our study, it was 1.5%. So future directions are to look at how tumor biology may play a role in our findings, exploring how more liberal use of partial biopsy techniques as a part of a standard workup may change patient outcomes, and examine whether these results hold true in the era of targeted and immunotherapy. Thank you.
This paper will be discussed by Dr. St. Hill from UNLV and then closed by Dr. Melanie Goldfarb.
Oh, it's actually Dr. Trevin Fisher. It'll be Dr. Trevin Fisher who will be closing. Thanks.
Good morning. I'm Randy St. Hill from UNLV in Las Vegas. I'd first like to thank the Western for the opportunity to review this excellently written paper and also to discuss it. Very nice job presenting. I have a list of 26 questions with A through E parts. I'll go through them now. I'll start with just the first two. The first thing I had a question about, do you know what the incidence of positive margin or residual melanoma is when the intent was for excisional biopsy as opposed to what you guys had? And then the second question is, in your study, you show there's several significant differences between the initial groups with respect to age and other important clinical pathologic characteristics. So you used a case matching method to control for these differences and minimize bias prior to the remainder of your analysis. Did you consider using propensity score matching method to achieve this reduction in bias? And if not, then why?
Great, well thank you, Dr. Ujiki, for the opportunity to present our work today. Thank you to the Western and Dr. St. Hill for these questions. We initially looked at sort of the whole cohort of patients in MSLT1, both excisional and those who had sort of a partial or had a partial biopsy. The rate of positive margin in those who had a positive, who had an excisional biopsy was very low, less than 10%. And we wanted to sort of, in our clinical practice, we're seeing very few excisional biopsy patients come to us with as their mechanism of diagnosis, and then the vast majority with a partial biopsy technique. So we wanted to look to see if those patients had any changes in their outcomes. And so that's why we chose to limit, sort of to exclude the excisional biopsy patients up front. In regards to your second question, given, we discussed this with our statistician, she felt that the sort of the database in its cohort had roughly equal patients who had both. I think 55 to 45% of those who had wide excisions with residual versus not, and thought that matched pairing would provide enough of a reduction in bias. Some of the biases that Dr. Ramiskal mentioned, I think that may go into this, or what were the clinical factors that led to someone having an excisional biopsy or not, or a partial technique. And so those are things we just can't answer from the data set.
This paper's open for discussion.
Hi, Chuck Scoggins from Louisville. Nicely done. Rob Martin presented very similar data in 2005, data from the Sunbelt Melanoma Trial. We presented that at the Southwestern Surgical, I think it might have been in San Antonio that year. And he showed that for the Sunbelt, there were about 20% of patients who have a shave biopsy. The dermatologists and the family practice docs do a lot of shave biopsies on a lot of things. And we only had 4% of patients after a shave biopsy have residual melanoma at the time of the wide local excision, and showed the exact same thing, that there was no impact on outcomes. I'm just wondering, Given that, and given your results, is there any push from our society and from others to impact how dermatologists and primary care physicians are doing biopsies on lesions that they're biopsying in the office? Thanks.
Yeah, so I think that we reviewed that paper sort of in our manuscript presentation. I believe the Sunbelt trial looked at patients less than 2 millimeters, at least in that publication, which one would expect a shave biopsy having a little bit greater of a chance to get a thinner, complete excision on a thinner lesion. We included all sizes that were in MSLT. And I think, we review NCCN guidelines, all the time in our fellows conferences. I think we were a little surprised how NCCN hasn't caught up to the practice of what's really happening in the community, especially with, this is not our data is not the first that suggests, like you said, that there's no major significant differences in survival. So I think, a growing body of work should suggest this, and, I think pushing for guideline changes may be coming.
Terry Larimore from LSU Shreveport. I enjoyed your study. I want to ask a brief clarification question about how your study was designed. If I understand, your definition of a partial biopsy was those patients who had residual disease of any kind after their diagnostic biopsy. My question would be, this would include not just patients who got a shave biopsy or a partial thickness biopsy where the full thickness wasn't obtained and the T-stage might be understaged, but also patients who had a positive radial margin, so that they still had a full thickness excision and they had an accurate Breslow depth diagnosed. Do you have any sense for how many of the patients that in your study who had a partial biopsy were patients who had a full thickness biopsy versus a shave biopsy, or just the patients who had a positive radial margin? Thank you.
Yeah, thank you for that. So we excluded up front those who had a true excisional biopsy, so one, requiring, closure with suture. So the partial biopsy techniques included a punch, a shave, or an incisional biopsy, where the intent was not to remove the whole lesion. So we up front excluded those patients who had. We did look at sort of where the margin was positive, and I believe about 40% were positive in the deep margin. I don't, off the top of my head, remember the number of the peripheral margin, but we do sort of wonder if the peripheral margin positivity in truncal melanomas could theoretically provide some sort of immunologic response to help improve survival. I think this is something we need to look at a little bit deeper, is if there are any molecular markers or immunologic profile that we can see this data, replicated.
Thank you. Our next paper number 10, the impact of low-dose aspirin on outcomes in patients with traumatic intracranial hemorrhage, a retrospective cohort study, will be presented by Andrew Webb, Oregon Health and Science University.
Hi everyone, my name is Andy Webb. Thank you for the opportunity for presenting our research here at WSA. I'm a current neurocritical care pharmacist at Massachusetts General Hospital, but I completed my critical care training at OHSU where I did this work. Here's our study team and our disclosures. The bulk of us don't have any disclosures, but Martin Schreiber is a consultant for humanetics, although that has no relevance to this particular research. So for a brief bit of background, traumatic brain injury is incredibly common, and many of these patients do present, especially to trauma centers, and can be a burden on the resources available in the healthcare system nationwide. And so methods to stratify the risk of progression and poor outcomes in these patients are very relevant to surgeons and clinicians taking care of these patients. And the brain injury guideline, or the big criteria, is one of those risk stratification methods for patients with traumatic brain injury. Initially kind of designed in order to identify patients who would most likely benefit from neurosurgical consultation versus those who could be cared primarily by acute care surgeons and trauma surgeons. The criteria, which I'll introduce on the next slide, break patients into 3 groups, big 1, big 2, and big 3, which are aimed to basically identify those patients who have the minor trauma, who really do not need intensive monitoring, versus those with major trauma, or big 3, who do really require ICU care and intensive monitoring in an ICU setting. These criteria have been prospectively validated in multiple centers and are implemented across many trauma centers to help balance some of the resource needs. OHSU is one of those centers that has prospectively validated the big criteria themselves, and these are the criteria which we took from the original study from Joseph et al., which basically classify patients by their symptomatology based on the GCS score, their presence of pre-hospital anticoagulant or antiplatelet use, the presence of a skull fracture, and the size and severity of their intracerebral bleeding. And based on their classification per this guideline, they'll disposition within the hospital will be determined by their group. So for instance, big one, those patients with the least severe trauma can be observed in our emergency department observation unit for a 24-hour period without kind of involvement of neurosurgery, versus big three, our most severe trauma patients do require a 24-hour ICU admission with Q1 hour neuro checks, repeat imaging, and kind of the whole ICU package. Of note, if patients have any of the most severe criteria, they'll automatically be put in that severe criteria. So of note, if a patient comes in with a relatively minor trauma, but is on, say, a low-dose aspirin, they will automatically be big three. So our study question was basically whether patients with otherwise minor trauma who are on low-dose aspirin experienced outcomes different than other big three patients. We really wanted to assess whether or not we could basically treat patients with minor trauma on low-dose aspirin as a general minor trauma patient, rather than lumping them in with the more major or severe trauma patients that we take care of in that big three category. So this was a single center retrospective cohort study of patients identified through the OHSU trauma registry, including adult patients over the age of 18 who had traumatic bleeding detected on head CT and were evaluated for big categorization, as all traumatic brain injury patients are at OHSU. We excluded patients with indeterminate big status. These are primarily patients who, say, had an aneurysm detected on CTA. It was unclear whether they fell because their aneurysm popped or the aneurysm popped and that caused them to fall. If they were transferred out of OHSU, or if they were transferred in for non-trauma care, and also excluded patients with missing outcome documentation, primarily those with missing head CT imaging. Our primary endpoint was the composite of neurosurgical intervention and all-cause in-hospital mortality across our 4 groups. So we had big 1, big 2, and big 3, as well as a 4th group of patients on low-dose aspirin who otherwise would have been big 1. Our secondary endpoints included the rate of traumatic intracerebral hemorrhage progression, as well as predictors of the primary endpoint using univariate and multivariable regression to identify those predictors. We screened 1,600 patients from our trauma registry, excluding 80 patients and ultimately including a total of 1,520 patients in our overall cohort. 200 of those patients were big 1 initially, 92 were identified as being big 1 but on a low-dose aspirin, 103 patients were big 3, and 1,125 patients were big 3 initially. Go through some baseline characteristics, just highlighting the kind of pertinent details within these tables. So across all of our groups here, kind of the top line baseline characteristics. I'd like to kind of focus in on how the big 1 and big 1 on aspirin groups are relatively similar versus the big 1 on aspirin versus big 3. So in terms of age, gender, GCS, ISS, and AIS head, really the only difference between the big 1 on aspirin and the other big 1 patients is age. Not incredibly surprising, as we're generally in a more elderly population are going to be the ones taking low-dose aspirin. But otherwise, their distribution of Glasgow Coma Scale at presentation, the distribution of their ISS score, and the distribution of their AIS head score are all relatively similar between big 1 and big 1 on aspirin. In terms of the mechanism of injury, also relatively similar, with the biggest difference in the big 1 on aspirin group being ground level fall, being the primary mechanism of injury, which again, not particularly surprising with our more elderly population. Whereas in the big 3 group, we have more of a distribution toward things like fall from height, motor vehicle crashes, the more severe mechanisms of injury for these trauma patients. Additionally, we do get tags on all of our trauma activations within the emergency department. Interestingly, the kind of R time, K time, alpha angle, and maximum amplitude, the primary tag values, are pretty similar across all of the groups. But I do want to point out that we do get platelet mapping on patients who are presumed to be on an antiplatelet at baseline. And unsurprisingly, patients on aspirin had a higher arachidonic acid inhibition level, likely reflective of their aspirin use. And also of note, patients in the big 3 group did have a relatively higher ADP inhibition, likely reflective of the severity of injury. Last bit of kind of baseline characteristic is looking at some of the bleeding characteristics of these patients. So this is basically of the patients, what proportion of the patients in each of these groups had a subdural hematoma, traumatic subarachnoid hemorrhage, intraventricular hemorrhage, intraparenchymal hemorrhage, or epidural hematoma. And what I want to really highlight here is that when you're looking at the distribution of the bleeding types, the big 1 and the big 1 on aspirin groups are relatively similar. And there are some kind of pertinent differences between the big 1 on aspirin and the big 3 group, which within clinical care they would normally have been lumped into. So in particular, patients in the big 3 group had significantly more traumatic subarachnoid hemorrhages, significantly more intraparenchymal hemorrhages, and significantly more epidural hemorrhages. So this kind of led us into really looking at our primary endpoint, whether or not the outcomes of these patients on low-dose aspirin differed significantly. And really right off the bat, you can see that when we really took out those patients with relatively minor trauma who were on aspirin, their rate of needing neurosurgical intervention, which would be a craniectomy, an EVD placement, a burr hole, or those sorts of things, was really not different from either the big 1 or the big 2 group, versus the big 3 group who truly did need that higher level of care with a much higher rate of neurosurgical procedure and in-hospital mortality. In terms of some secondary endpoints, I'll go through some kind of pertinent ones here. In terms of just breaking out the individual endpoints themselves, you can see that, again, the number of patients who experience in-hospital mortality was low across the big 1 on aspirin, and big 2 group, generally reflective of patients changing their level of care and going towards comfort care after a traumatic event, and none of those patients required a neurosurgical intervention. In terms of the number of 28 hospital-free days and 28 ICU-free days, the big 1 and big 2 groups understandably had more hospital-free days, and the big 1 and aspirin group had fewer hospital and ICU-free days simply because of our protocol that would keep them in the hospital longer, versus the big 3 group, which had much fewer hospital-free days and ICU-free days. Additionally, we looked at the rate of progression on repeat scans, if patients did get repeat scans, and the patients in the big 1 on aspirin group did not have a higher rate of ICH progression compared to the big 3 group, and were much more similar to the big 1 group, which we really wanted to be able to lump them in with. We also tried to see if we could identify predictors of experiencing that primary endpoint, that in-hospital mortality or neurosurgery. And interestingly, we looked at antiplatelet use, anticoagulant use, and antiplatelet use itself did not result in an increased odds of experiencing the primary endpoint. We did identify male sex, each 1 point increase in injury severity scale, each 10 milligram per deciliter decrease in fibrinogen, and blood product administration or the presence of a subdural hematoma were all predictors of the primary endpoint, and aspirin use itself was not. So our conclusion was that patients with otherwise big 1 grade TBIs on low-dose aspirin have a much lower risk of poor outcomes than patients in the big 3 group. And functionally what this means for patient care is that these patients who otherwise kind of have minor trauma but are on low-dose aspirin likely don't necessitate the high level of ICU care that the big criteria kind of portend them to have. So in institutions that use the big criteria to grade how they will stratify their resource utilization, getting rid of the low-dose aspirin as a requirement for ICU care may actually have significant savings both for the institution as well as for those patients not having to kind of be subjected to Q1 hour neurochecks for an entire 24-hour period. So I'll turn it over to my invited discussant, and I'm looking forward to questions.
Dr. Steve Smith from University of Florida will be discussing this paper.
I want to thank the authors for a well-written paper that was provided to me well in advance of the meeting and for an interesting presentation. This is an important topic. The patient population seen by most trauma centers is markedly different than previous decades. In fact, the average trauma patient is older, has more medical comorbidities, and is almost certainly taking prescription medications. In many trauma centers, the most common mechanism of injury is a ground level fall in a geriatric patient who is probably taking antiplatelet agents, anticoagulants, or both. This situation requires a trauma surgeon to frequently answer the question of how and where best to care for these patients. If only an isolated minor intracranial injury is present, this situation frequently results in a sometimes heated debate regarding the admitting service and unit. These are not highly sought after patients as their care is largely non-surgical and is frequently complicated. The use of the brain injury guidelines, or big criteria, by several groups has been shown to be useful in stratifying these patients and providing a method to determine the best approach to care, including identification of the admitting service. This paper helps to further refine this method of assessment by focusing very specifically on otherwise low risk or big 1 patients who have traditionally been elevated to the big 3 higher risk category simply because they had a history of low dose aspirin therapy. The results are encouraging and indicate that 81 milligram aspirin administration does not justify a high risk categorization. I have 3 questions. How many of the big 1 patients taking low dose aspirin in this retrospective study received medications or platelet transfusions to reverse the potential effects of antiplatelet agents? 2, In Big 1 patients that received low-dose aspirin that were assessed with thromboelastography and platelet mapping, notable differences were found. Admittedly, the differences with TEG results are not specifically associated with platelet inhibition. The group with TEG appeared to be more likely to have a poor outcome. Why should TEG and platelet mapping not be used routinely to stratify risk in these patients? And finally, based on the result of this study, has current clinical practice changed in your hospital? In other words, are big patients with a history of taking low-dose aspirin no longer considered high-risk Big 3? Are they actually observed in the emergency department or admitted to the trauma service with minimal or no involvement of neurosurgery? This approach would not be easily implemented at my institution, as both the emergency department and inpatient trauma services are already very busy, but busier than our neurosurgical colleagues. Thanks again for a great presentation.
Thank you for the excellent discussion. So I'll address each of your questions. So in terms of the rate of reversal of these patients, it was actually interesting. We did collect that data in terms of how many of these patients received specific reversal agents for their antiplatelet agent. And interestingly, of all the patients on aspirin, about 25% did receive a platelet transfusion. But when we pulled out specifically the patients who were Big 1 on aspirin, only around 8% of them actually received transfusion. And I think that kind of reflects that at the bedside when these patients present as a trauma activation, I think it's pretty much recognized that the care of these patients is not going to need kind of the intensive amount of monitoring and attention that many of our trauma patients do. And we actually did not find that reversal of the antiplatelet effects actually impacted the outcome itself. That was one of the factors that we included in the model that did not achieve statistical significance. Then your second question about using TEG with platelet mapping is a really interesting one. It's a question that our group has had ourselves, and there's actually a manuscript kind of forthcoming that addresses that specific question. And in a separate cohort of patients taking antiplatelets that we got platelet mapping on, we did not find an association with AA inhibition and change in outcomes, although we did find an association with ADP inhibition. I think that's reflective, as has been shown in several papers, that ADP inhibition is correlative with the severity of trauma and not necessarily with the effect of the antiplatelet agent. There is another paper that our group actually just published in the Journal of Trauma and Acute Care Surgery that looked at using platelet mapping to identify whether or not patients are on an antiplatelet agent. And we did actually find that kind of quote-unquote normal platelet mapping values did seem to suggest that patients were not on antiplatelets. So that could be one thing that we could use platelet mapping for without necessarily using it to stratify the severity of trauma. And then your last question about change in practice, it's kind of going through the committees, as they say, about changing our big criteria right now. We're kind of lucky in that we have kind of dedicated units where these patients can go. I think your point about every service being quite busy is incredibly valid. And luckily, our emergency department observation unit is staffed in such a way that these patients can be monitored overnight without needing a neurosurgery or a trauma fellow to be involved with the care of that patient. So hopefully in the coming months, we'll be able to see that practice change made, and then we'll be able to kind of prospectively look at what that change may have as an impact on patient outcomes.
We have time for some quick questions. We'll go left, right, left, right.
Yeah, Cherkovich, Sacramento, thank you for the podium. Nice paper, and I enjoyed Dr. Smith's discussion of putting this into perspective of why it's important. If I read the data correctly, there were 2 deaths in the Big 1 and 2 deaths in the Big 1 on aspirin. But mortality was your primary endpoint. I might challenge that as being the appropriate endpoint for this paper and ask you to comment on what exactly were the causes of mortality in those 4 patients.
Yeah, that's a great question, and we had the same kind of thought about, just all-cause mortality may not capture exactly what's going on with those patients. So we did drill down specifically into what was the mechanism of death in those patients. And in all 4 of those patients in the Big 1 and the Big 1 on aspirin group, they were elderly patients who this was a subsequent fall of many falls, and there was a goals of care discussion, and it was just changed to end-of-life care. So the trauma itself was not the mechanism of the death, rather that it was just kind of a marker of where they were. Thank you.
Laura Denver, very nice. This discussion, though, has broad implications, as you may be aware. For reasons that astound me, neurosurgeons believe aspirin is toxic. They absolutely fear it. And in our institution, for example, although we argue daily, they preclude aspirin use for 7 days after any intracranial hemorrhage. And therefore, we have to treat patients with IV heparin drip, interestingly, running at PTTs of 80, and yet they're afraid of 81 milligrams of aspirin. The other implication, though, is that we need to be careful and educate our neurosurgical colleagues and now our emergency medicine colleagues that just because you're in antiplatelet therapy doesn't warrant platelet transfusion. In fact, you may be aware, if you read through this, the PATCH study. The PATCH study came out 3 years ago in Lancet. It was a huge multi-center trial, and patients who were brought to the emergency part were treated with platelets if they had antiplatelet therapy. In fact, the mortality was doubled if you had presumptive platelet therapy. And then finally, the issue of the TAG and use for mapping of platelets, as you know, is confounded because the TAG, unless you isolate the platelets, has such a robust thrombin activity that it totally precludes any signal from aspirin. And we've similarly shown that both arachidonic acid and ADP responses in trauma have no relevance to their outcome and need for platelets. Thank you very much.
Yeah, thanks for that great discussion. I think that your points are all incredibly valid, that there's quite a bit of folklore that goes into what may or may not require intervention or that sort of thing. I think the PATCH trial and the argument that that's all spontaneous and not traumatic is a point of education. I definitely agree.
Collins, Los Angeles, thank you for a fascinating study. I noticed that persistent neurologic injury was not one of your secondary endpoints. So we go from mortality to discharge home and not much in between, and yet some of the patients had pretty scary things: subarachnoid hemorrhage, intraparenchymal hemorrhage, epidural hematoma. So that's one thing. The other is the USPTF has gotten very lukewarm on the use of aspirin. So today is the last day for public comment on the 2021 update of the guidelines, which looks like it'll be even more tepid than the 2019 guidelines. So when you say get rid of aspirin, do you literally mean get rid of aspirin?
Yeah, those are two excellent questions. And unfortunately, being kind of a referral center for trauma, we don't have long-term follow-up data with many of the trauma patients. Like, as many of you likely experienced, trauma clinic has sometimes difficult to have follow-up with those patients. So I agree that having long-standing neurologic information in terms of their function would be incredibly valuable, but unfortunately it just wasn't possible for us to collect that data. And at least in my personal clinical practice, I definitely agree with you, where if patients are on aspirin for primary prevention, it is my mission to get them off the aspirin. So there's a growing body of evidence that universal aspirin use probably does a lot more harm than good. And hopefully if there's a trend towards practice of getting more elderly patients off their primary prevention aspirin, this may be even a moot point in the future. So definitely great points to be made.
Okay, one brief question, please.
Hi, Tom Sutton from Portland, Oregon. I just wanted to thank you for doing this study on behalf of the OHSU trauma residents, because as an ICU resident myself, I know that I feel like I've written more than 92 ICU admission notes for Big One patients who were otherwise Big One except for being on aspirin. My question for you, though, is do you think that it's, given the low number of patients experiencing your endpoint 4 in total in the Big One group, do you think that following a different endpoint and using other Big One groups to say, look at the effect of platelet transfusions on normalization of added risk from aspirin might allow you to better justify observing these patients in a lower acuity setting?
Yeah, it's a great question and something that we're definitely looking at, where we have this data set as well as another data set of all additional platelet mapping, and we're trying to kind of get away from platelet mapping testing in many of these patients for a number of reasons. One, that sometimes getting the platelet mapping itself can trigger the instinct to reverse with platelets, and given the blood factor shortage, we're trying to see if we can prove that that may not actually impact outcomes itself. So I think ideally we can identify the lowest risk patients taking low-dose aspirin, and then identify how we can use either the TEG values or the platelet mapping values to make sure that they don't experience poor outcomes and avoid the ICU stay altogether.
Thank you.
Thanks so much.
Paper number 11, Evolving Management of Early-Stage Pancreatic Adenocarcinoma in Elderly Patients, an analysis of the National Cancer Database, will be presented by Dr. Sean Nasoy from St. John's Cancer Institute.
Thank you for the opportunity to present our data here today. Okay. Thank you. So again, my name is Sean Nassler. I'm from the Donald L. Morton Fellowship. We're going to be presenting our paper on the evolving management of early-stage pancreatic cancer in elderly patients. And we have no disclosures. Pancreatic cancer is the fourth leading cause of cancer-related death in the United States. Due to the aging population, its incidence is expected to continue to increase. It is estimated that pancreatic cancer will have 60,430 new cases this upcoming year, with an estimated 48,220 deaths, greater than 2/3 of which will occur in patients who are over the age of 70. The current recommendations for early-stage resectable pancreatic cancer are for patients to undergo an upfront surgery approach, and an integral component of their treatment involves the receipt of adjuvant systemic therapy with or without radiation. However, there are a subset of upfront surgery patients who are unable to start or complete their adjuvant therapy, and some studies have estimated that this number may be as high as 50 to 60% of patients. For that reason, and for others, there has become interest in applying a neoadjuvant therapy approach for resectable pancreatic cancer. Proponents of this approach advocate that neoadjuvant therapy potentially allows for downstaging, controlling micrometastases, and selecting patients whose tumor biology is more favorable. Regardless of the sequence, many of the trials that have evaluated the role of systemic therapy have either excluded patients over the age of 70, or those patients are vastly underrepresented. And moreover, the ideal sequence of therapy in older patients has not been purposely studied. So our objective was to evaluate the trends in management of elderly patients with early-stage pancreatic adenocarcinoma that had undergone a pancreaticoduodenectomy. Our primary outcome of interest was overall survival, and our secondary outcomes of interest were factors that were associated with an R0 resection, factors associated with the receipt of neoadjuvant therapy, and factors associated with the receipt of adjuvant therapy. So we performed a retrospective review. We utilized the National Cancer Database, which captures 70% of cancers in the United States, and facilities are required to have at least 90% follow-up over a 5-year period. And we did this between the years of 2010 to 2016. As part of our inclusion criteria, we looked at only patients who were greater than or equal to 7 years of age. They were histologically confirmed pancreatic ductal adenocarcinoma. These were clinical T1 through 3 lesions. They were node negative without any evidence of metastatic disease. The lesions were confined to the pancreatic head, neck, or body. Patients had to have undergone either a pancreaticoduodenectomy or an extended Whipple. And we then grouped our patients into one of 3 groups based on the sequence of their therapy, either upfront surgery alone, upfront surgery with the addition of adjuvant therapy, or neoadjuvant therapy followed by surgical resection. Baseline characteristics were compared using chi-square tests and ANOVA analyses. Trends over time and utilization of neoadjuvant versus upfront surgery with and without adjuvant therapy were performed. Multivariable logistic regression analyses were performed to examine factors that contributed to R0 resection, receipt of neoadjuvant therapy, and receipt of adjuvant therapy. Our overall survival was calculated from diagnosis to the time of death or last known follow-up and compared using the Kaplan-Meier method with log-rank test. And to account for the immortal time bias, 6-month conditional landmark analyses were further performed. In total, we identified 5,086 patients that met our inclusion criteria. We had 51.7% of patients that underwent an upfront surgery approach with the addition of adjuvant therapy. 29.9% of patients had an upfront surgery alone approach, and 18.4% of our patients underwent neoadjuvant therapy followed by surgical resection. When we looked at all of our patients, a majority of our patients were in the younger group, 70 to 79 years of age. They were female, Caucasian, had public or government insurance, received their care at an academic facility. They had lower comorbidity scores. Most patients had T2 or T3 lesions, and most patients underwent an R0 resection. This next figure just looks at the trends over time and how these patients were managed. And the blue bar graph corresponds to those patients that received neoadjuvant therapy. And so as you can see from the start of our study period in 2010 until 2016, the percentage of patients that received neoadjuvant therapy increased. And the greatest increase was seen from 2015 to 2016, where it was 1 in 5 patients, and it increased to 1 out of every 3 in 2016. When we looked at our individual treatment groups, our neoadjuvant therapy group, those patients were more likely in the younger group. They had lower comorbidity scores. They had larger lesions with T3 and higher or elevated preoperative CA 19-9 levels. More than half of our patients received radiation as part of their neoadjuvant treatment, and about 70% of patients received multi-agent chemotherapy. And there was a 90-day mortality rate of 7.3% in the neoadjuvant therapy group. In our upfront surgery with adjuvant therapy group, these patients were also younger, 70 to 79. They had lower comorbidity scores. Most of these patients had T2 lesions. About a third of these patients underwent radiation, and a majority of these patients received a single-agent chemotherapy regimen as their systemic therapy. And in our upfront surgery alone group, these patients were older, they had higher comorbidity scores, they had T2 tumors, and they actually had a 90-day mortality rate of 20%. So when we looked at our secondary outcomes of interest, we found that patients that received neoadjuvant therapy were 49% more likely to undergo an R0 resection. We also found that other factors that were associated with an R0 resection were smaller tumors, normal preoperative CA19-9 level, and receipt of care at an academic facility. When we looked at factors that were associated with the receipt of neoadjuvant therapy, we found that younger patients with lower comorbidity scores and patients with larger tumors and patients who received their care at an academic facility were more likely to receive neoadjuvant therapy. And we also looked at factors that were associated with the receipt or not receipt of adjuvant therapy, and we found that older patients and higher comorbidity scores were less likely to receive adjuvant therapy, whereas patients that were node positive was associated with the receipt of adjuvant therapy. And then in regards to our primary outcome of interest, this is our Kaplan-Meier curve initially comparing overall survival for patients in the neoadjuvant therapy group versus all upfront surgery patients. And the blue line again corresponds to our neoadjuvant therapy group. And as you can see here, our neoadjuvant therapy group had improved overall survival in comparison to our upfront surgery group, with a median overall survival of 27.8 months for neoadjuvant therapy versus 20.9 for the upfront surgery group. Knowing that the patients in the upfront surgery group alone performed worse than the patients who had upfront surgery with the addition of adjuvant therapy, we then compared our neoadjuvant therapy group to only those patients that received upfront surgery with the addition of adjuvant therapy. And the benefit of neoadjuvant therapy was maintained with a overall survival of 27.8 months for our neoadjuvant therapy group versus 24.4 months for our upfront surgery with adjuvant therapy group. In addition to neoadjuvant therapy being associated with improved overall survival, we also found that receipt of care at an academic facility and having undergone an R0 resection were associated with improved overall survival. Upfront surgery alone, older patients, so greater than 80 years old, patients with more comorbidities, patients with T2 and T3 lesions, and elevated CA19-9 preoperatively was associated with worse overall survival. There are some limitations to our study. We use T1 through 3, N0, M0 as a surrogate for resectable pancreatic cancer. So in this way, we could have inadvertently included locally advanced or borderline resectable patients in our analysis. In addition, with our neoadjuvant therapy patients, perhaps the biggest limitation is that we're not able to identify patients that were scheduled to receive neoadjuvant therapy but were unable to undergo resection due to either intolerance of the neoadjuvant therapy or due to progression of their disease. As well, we don't have granular data about the systemic therapy regimens other than it was a single or a multi-agent. In addition, because our study is from 2010 to 2016, it's possible the regimens used are not necessarily reflective of the treatments that are applied today, as well as inherent limitations of the NCDB in a retrospective study. We found that most older patients that were diagnosed with early stage pancreatic cancer that were considered for resection received an upfront surgery approach. However, we found that neoadjuvant therapy was associated with improved R0 resection rates and a significant survival benefit. And this remained true even when we compared against only those patients that had upfront surgery with the addition of adjuvant therapy. Perhaps one of the problems with upfront surgery is that we're not able to predict which patients will be unable to receive adjuvant therapy. And we found within our group of upfront surgery alone patients that more than half of those patients over the age of 80 who have upfront surgery do not receive adjuvant therapy. And while that is within the range that's actually reported in the literature, it seems to be unacceptably high. And interestingly, and which has not been reported prior, is our upfront surgery alone group had a 30-day mortality rate of 10% and a 90-day mortality rate of 20%. So we feel that neoadjuvant therapy may be the optimal sequence of therapy in older patients with pancreatic cancer. The age of a patient should not preclude them for consideration for neoadjuvant therapy. And neoadjuvant therapy should be discussed with all elderly patients that are being considered for resection. And perhaps the application of neoadjuvant therapy is another tool that can be used to select the most fit patients for a Whipple. Thank you.
This paper will be discussed by Dr. Michael Egger from University of Louisville and closed by Dr. Melanie Goldfarb.
Good morning. I would like to thank the Western Surgical Association for the opportunity to discuss this paper that investigates an important question that we face every day, namely that of neoadjuvant therapy in patients with pancreatic cancer who are over 70. Whenever I read papers from the NCDB, I ask myself whether the researcher is asking the right questions and whether the NCDB is the appropriate data set to answer those questions. The NCDB is particularly useful to evaluate trends in management over time. In that respect, this paper provides an excellent evaluation of the evolution in the management of elderly patients with pancreatic cancer. It gets a little trickier to play the this treatment is better than that treatment game, given the inherent limitations of the NCDB, which were discussed. There is no eyeball test variable, the dedicated family that will take care of this patient and their complications after surgery variable, or this patient doesn't even have money for bus fare and we need to operate on them now because this is the only chance that we can get to take care of them variable. We use these variables every day to try to make treatment decisions in this age group. Importantly, the NCDB does not have data on loss of independence and disposition at discharge, which are particularly important endpoints to the patients and their families in this age group. With these limitations in mind, the authors do a reasonable job of adjusting for selection bias using fairly sophisticated but well-described methods to reach the conclusion that older patients with resectable pancreatic cancer likely do better if they are given neoadjuvant chemotherapy. It's always surprising to me when I read these studies about how many people are still treated with an upfront surgery approach. In our practice at the University of Louisville, I would think easily that 75% of our patients are treated with a neoadjuvant approach at this time. Even though there's a time lag, as recently as in 2016, still only 30% of patients in this study were receiving neoadjuvant therapy nationwide. I think this is a fascinating story that is unfolding about how new treatment paradigms are disseminated and adopted into wider clinical practice. This is pancreatic cancer treatment in the real world, and it's not always what we expect. I have two questions for the authors. The authors use the term unable to receive adjuvant therapy to describe the upfront surgery group. Certainly there are patients who are unwilling to receive chemotherapy, and that decision is made as a deliberate choice between them and their oncologist, with or without the surgeon's blessing. Do the authors think it's appropriate to offer operative resection to a patient in this age group who will not agree to receive chemotherapy or is not well enough to receive chemotherapy, either in the neoadjuvant or adjuvant setting? How do you counsel such a patient? And finally, my oncology partners are reminding me at Tumor Board every week that we have the Alliance 21806 trial open, in which patients with resectable pancreatic ductal adenocarcinoma are being randomized to adjuvant versus neoadjuvant therapy. Is your center enrolling in this trial, and should patients over 70 be considered for this trial based on your study? Again, I would like to thank the Western Surgical for the opportunity to discuss the paper and congratulate the authors on a well-written and thoughtful manuscript.
Thank you, Dr. Eggers, for that insightful questions and a great discussion, and thank you to the Western for our opportunity to present. I'm going to answer both of these questions actually as general statements. So, your question for the Alliance trial, we are actually a new Alliance member thanks to one of our other surgeons, so I think this is something we will look at starting in our institution, but I think in general we should start offering clinical trials such as this to patients of an extended age group, both at the older and younger ends, because those are the patients that have historically not been offered clinical trials, and papers like this come out showing that, well, we think we know what's going on, but we don't. So I think we really need to start offering clinical trials to an expanded age group. And similarly, to ask your first question is more of an ethical question. Do we refuse to treat patients that are not going to accept all of our treatment recommendations? And I think that comes down to an individual basis, both for pancreas cancer as well as for other cancers. I would hate to refuse somebody all treatment because there is an advantage to getting some treatment, and I think again, it comes down to all those factors that you say we don't have access to in a big database. So what's their support? What's their overall frailty, which is another big topic in this age group? What's their mental status? What is their other tumor factors? So I think it is appropriate in some circumstances to offer some treatment when they refuse others, but maybe not in all. And this really needs to be a very informed conversation with the patient and his family. Thank you.
This paper is open for discussion.
Congratulations, enjoyed your talk. Honestly, this is, I think, a very important paper at Indiana. Often it's stated that, because of just a patient's age, that we'll go to single modality therapy, and they sort of push the patient towards the surgeon to have the biggest stress test they can instead of dipping their toe in the water with a round of chemo. Honestly, I don't get it, and I think it's age bias, to be quite honest, and I'm going to take your study back to Indiana and show that to them, because I think we're going in the wrong direction with this. The mortality numbers were staggering. I think I got a picture of it. It was going by pretty quickly, but I'd love to have a copy of your slides and present it to the group back in Indiana. Thanks again for bringing it to the Western.
Thanks for that, and we'll be happy to give you our slides.
Any other questions? Thank you.
Thanks. We got off
Paper number 12, 5-year experience with laparoscopic transcystic common bile duct exploration. This will be presented by Dr. Irving George, Mayo Clinic, Arizona.
Hello, good morning, and thank you to Western Surgical for allowing me to present this paper. So I have no financial conflict of interest or disclosures. So a little bit about the overview of what I'm going to talk about today. First is background. We'll look into the methods of the paper, so I'm going to show some cases and the results of our experience. So about 10 to 20% of patients with cholelithiasis have cholelithiasis, and following the SAGE's 6-step guidelines, every laparoscopic cholecystectomy should include a cholangiogram. Routine cholangiogram helps identify common bile duct stones and actually has helped us develop the skills for the lab common bile duct exploration. So when you find yourself with a patient with cholelithiasis, there's multiple ways to approach it. The most common, patients get an MRCP, ERCP, and a lab chole to follow. Some patients in some centers will go to EUS, ERCP, and a lab chole. Others, you can do a lab chole with a cholangiogram. If you find stones, they go to ERCP. And what I'm going to talk about a little bit today is the lab cholecystectomy with cholangiogram and common bile duct exploration. So our paper was basically to evaluate our experience over 5 years during doing this procedure, and in a 5-year period did about 106 lab common bile duct explorations. This was a retrospective review from 2015 to 2019. Patient characteristics is the same that what you're going to see on your average biliary colic acute cholecystitis population. And the outcomes of our 106 patients, so 28 patients in total ended up having an ERCP, 15 of these preoperatively, and 13 post-op, and I'll explain a little bit more about that later. Now, the patients that did not have a preoperative ERCP, which was 91, we cleared 78 common bile ducts for a success rate of 86%. Our mean operative time was about 2 hours, and our length of stay in the single-stage procedure was decreased by 1 day. So let's go into a couple of the cases. In case number 1, we have a 43-year-old male with elevated liver function test, ultrasound consistent with acute cholecystitis, and a dilated common bile duct. He had an MRCP from his presentation to the emergency room, and you can see a filling defect down there at the distal common bile duct. So this patient we take to the operating room, and we do a cholangiogram, and we find our stone at the distal CBD, and this is a before and after cholangiogram. And I'll show a little bit about how we do this. In case number 2, we have a 59-year-old female with pretty normal ALT and AST and a mildly elevated T-billy. And on the routine cholangiography, which I always do, we see this filling defect down at the distal common bile duct with very, very little filling of the duodenum. So at that moment, we do a Seldinger technique and pass an introducer and dilator into the cystic duct, pass a glide wire down into the duodenum, and perform our CBD expiration. So in this patient, what we do is we pass the wire, pass a balloon and place it at the ampulla, give the patient 1 milligram of glucagon IV, this is done by an anesthesiologist, and we dilate the ampulla and hold it there for a minute. After that, we pull our balloon back to the cystic duct, we flush and do a completion cholangiogram, and there we've cleared the stone. So this was another patient, and here we see normal liver function test on this patient had a very large gallstone, and we see this common bile duct very dilated and full of stones and debris down there at the bottom. So same thing, we do our Seldinger technique, and we pass a glide wire with our balloon down to the ampulla, dilate the ampulla, and you see it being dilated there. We hold it for about a minute, keeping the balloon inflated, withdraw our balloon, put it at the cystic duct, flush, and do our completion cholangiogram, and we see here the clearance of the common bile duct. Case number 4, similar routine cholangiography. We find this small filling defect down here at the bottom, pass our wire and our balloon, dilate the ampulla, and completion cholangiography, and we're done. So the equipment needed for this is nothing actually very special. This we actually take out of the vascular trays. We use a introducer, a dilator, an introducer, a glide wire. The balloon, depending on the size of the common bile duct, we use either a 6 French or an 8 French balloon, and an inflation device to hold the balloon up inflated for about a minute. For most hospitals and most physicians, they'll ask, is it worth doing this? And when you look at the reimbursement, the RVUs, when you do a laparoscopic cholecystectomy with a common bile duct expiration, it is worth your time, and it actually reimburses the institution for the extra time and equipment needed to perform this. If you do also cholecystectomy, that also adds to the procedure. So our results, at 5 years, we did 106 lap common bile duct expirations. 15 of these were, had preoperative ERCPs. At the beginning of our experience, we were very conservative. But on the subsequent lap chole, the day after, since we do routine cholangiograms, we did still find stones and debris in the common duct, which we cleared. 91 of those patients that did not have a preoperative ERCP, we cleared 78 of those ducts for an 86% success rate. And 13 of those that we, the 13 that we did not clear, they required an ERCP. That provides a combined clearance rate of 88%. Complications, we had 2 wound infections, 1 pneumonia, 1 right hepatic duct injury, which was probably due to a difficult dissection in the Callot's triangle. That required an ERCP and drain placement, and 1 case of pancreatitis. So conclusions and recommendations, routine cholangiogram helps identify stones even when imaging and liver function tests are normal. And routine cholangiography serves as a bridge to perform lap transcystic common bile duct explorations. The success rate in our hands and published literature is anywhere from 80 to 90%. And you should start with small stones, sludge, and debris. And if the patient is cholangitic, that should definitely go to ERCP first. Limitations of our study was retrospective. Our experience and learning curve improved as we did more of these, same as the equipment that we used over time. Questions?
This paper will be discussed by Dr. Mary Hahn, chairman from Stanford University.
Great, thank you. Congratulations on an excellent presentation and sharing your experience with laparoscopic common bile duct exploration. With the increased use of fluorescent cholangiography, as well as barriers to doing fluoroscopy like we have here in California, you need to have an independent fluoroscopy license from the state in order to do intraoperative cholangiography. I think fewer and fewer surgeons are less likely to be trained to even do cholangiography, let alone interventions like you described here. And I think this will likely further erode the surgeon's ability to even be able to technically do the diagnosis and the treatment of common bile duct stones. So I really personally enjoyed learning about your technique, and I think I will try to incorporate this into my practice. I think this is the future of general surgery. If we don't start taking catheter-based therapy, image-guided therapy, we're going to continue to lose less and less of our management of these complex disease processes. So my questions for you are, do you have an idea of what proportion of your patients seeing you do systematic cholangiography have common bile duct stones, and what proportion of those were asymptomatic that you just identified by your routine cholangiography? What's the evidence that we need to treat asymptomatic common bile duct stones? This is controversial, and most surgeons who don't do systematic cholangiography don't even know the stones are there. So are we overtreating the disease by doing this technique? And finally, what's the learning curve for this technique? So you said you were conservative early on, you went to ERCP first, and you recommend starting with smaller stones, but what was the learning curve? How many of these you have to do before you feel like you're really going to be successful? So congratulations on an excellent paper addressing a common and important topic that the general surgeon is becoming less capable of treating. I learned something that I will take back for treatment of my patients, and thank the Western Surgical for putting this paper on so we can all learn from you. Thank you.
Thank you. Thank you for the questions. So I think about 40 to 50% of our patients were actually asymptomatic stones. At the beginning of our experience, like I said, we were very conservative, and as we got a little bit more comfortable, we started to take on a little bit more symptomatic in patients with gastric bypasses that had known stones and so forth. So most of this was a product of routine cholangiography, this experience. And, you know, looking at the literature of routine cholangiography, the Swedes did a trial several years ago. They published about 2015. In Sweden, routine cholangiography is standard of care, and they compared routine cholangiography and identifying stones and leaving them untreated compared to intervention. And they found double in the risk of unfavorable outcomes, patients coming back with cholangitis, pancreatitis, and so forth. So they, after that trial, they actually intervene on patients, either lap transcystic explorations or ERCP, but they don't leave asymptomatic stones behind. And I'd say the learning curve, the hardest part of the procedure is really getting a good cholangiogram. Once you obtain a good cholangiogram, it's seldom your technique. You pass a wire, you pass a balloon. I'd say about 10 to 20 cases, and you're comfortable. I've been in Arizona for 5 months, and our residents there have done a couple with me, and now I can let them lead it, and it's been a handful.
We'll start on the left.
Thank you. Fascinating study. Full disclosure, Collins, Los Angeles, I'm a California surgeon. I have a fluoroscopy license, and I started my career doing routine intraoperative cholangiography. When I changed institutions, I became persuaded that something on the order of 80% of common duct stones are incidental and will not be of any clinical consequence. So our group does highly selective cholangiography and vanishingly rare transcystic exploration. I liked your balloon technique. So it sounds like we need to write a paper. Now my question for you is, do you stop short of instrumenting the duct? Do you use intravenous glucagon with power flushing, for example? for a 3-millimeter stone that might even pass spontaneously? Thank you.
So we do give all patients glucagon. Once we see that there's a stone there, we give the glucagon to help dilate the sphincter. Sometimes, all you need is a flush, and that's it, you're done. I learned many years ago, doing cholangiography helps me sleep at night. I know that my patient's not going to come back with a retained stone or pancreatitis or something like that. And it just became standard of care, and trained all the residents to do it. And once you actually have your x-ray techs and the nurses trained, it adds 10 minutes to the procedure.
Dan Margulies, Los Angeles. Thank you for that. It sounds quite interesting that you've, and congratulations on moving to your one-stage technique versus, 2 with the RCP. At Cedars, we have a long history of doing this, but our technique has been to remove the stones through common duct exploration, and all of my ACS guys have been trained to do that. The question I have is, this is kind of a different technique in that you're dilating the ampulla, and we've always tried to avoid that if we could, but it sounds like it's easier. Do you do this preferentially over removing stones, and if it fails, those 13 patients, would you consider just going after the stone and removing it rather than sending them to ERCP?
So we've used cholecystoscopy to remove stones, and that is much harder, and there's a lot of variables, tortuous cystic duct, small cystic ducts. Depending on the insertion of the cystic duct on the common bile duct, it makes it a lot more challenging. I feel that this is a good first step, and if you can't get the stone to clear, doing it fluoroscopically and the anatomy is suitable, you can pass a cholecystoscope. But this avoids a lot of cholecystoscopy and a lot of sort of the fear of trying to remove stones. And when you have a 6-millimeter stone and a 4-millimeter duct, it's not going to come out.
Dr. John.
Ben German, Gunderson, La Crosse, Wisconsin. This is really fun to review this work. So I had 2 questions. One is, we had an unfortunate experience with an elderly immunosuppressed patient that had a sphincteroplasty that then ruptured. It's a bad complication. And so we try to develop some criteria with who should have that done and who should just have an endoscope to remove the stone, either biliary, transcystic, or an ERCP. Have you found, are there any patients that you will not do a balloon sphincteroplasty on and do another technique? And the second question is, have you tried to coordinate with your GI team to come in the ER, to come in the OR under the same anesthetic and do the ERCP when you're not able to clear a duct to save patient costs?
I haven't explored the second option of getting GI to come into the room because that takes a lot of planning. And since a lot of these have been a product of routine cholangiography, I haven't known until I'm there that I'm doing this. When it comes to this sphincteroplasty, we always take a look at the size of the cystic duct before deciding what size balloon we're going to use. And I had done some research on ERCP pancreatitis because I was concerned about, am I going to have the same problem? And a lot of the hypothesis behind ERCP-induced pancreatitis is by manipulation from the duodenum up into the pancreatic duct. So we found in our experience, we had 1 case of pancreatitis, which could have been the wire going down into the pancreatic duct, but overall the incidence of post-ERCP pancreatitis is higher than transcystic explorations.
I'll remind everyone that we are debating later this afternoon the benefits of one-stage transcystic common bile duct exploration versus ERCP and lap chole, and this excellent presentation, I hope, whet your appetite. Thank you very much.
Thank you.
Well, our final paper, and I want to thank the speakers for remaining on time. The paper number 13, the impact of surgical delay on tumor upgrade and outcomes in estrogen receptor negative ductal carcinoma in situ patients. This will be presented by Dr. Kathy Yao from North Shore University Health System.
Thank you. I would like to thank the Western Surgical Association for the opportunity to present our work. I will be discussing the impact of surgical delay on tumor upgrade and outcomes in ER-negative DCIS patients. We have no disclosures. On March 13th, 2020, the American College of Surgeons issued a statement that all elective surgical procedures should be delayed, if not canceled, to preserve resources to take care of COVID-19 patients. And this statement had a large impact on patients with breast cancer, and you could argue whether breast cancer is an elective case or not, but nonetheless, many institutions across the country delayed breast cancer cases. After the American College of Surgeons statement was issued, many societies issued their recommendations, and this was a consortium statement from a multidisciplinary group of specialists and that issued recommendations for prioritization, treatment, and triage of breast cancer patients during the COVID-19 pandemic. They used a prioritization schema based on an Ottawa guideline. Priority A cases were cases that were immediately life-threatening. Priority B were cases that should not be delayed to the end of the pandemic but didn't have to go immediately. And priority C cases were cases that could be delayed until after the pandemic. Ductal carcinoma in situ, both estrogen receptor negative and estrogen receptor positive disease, was placed in the priority C category. But many breast surgeons expressed concern that because some DCIS cases can be upgraded to invasive disease at resection, that possibly ER-negative DCIS cases, we may be neglecting a triple-negative breast cancer. These are a few recent studies that have shown the tumor upgrade rates for DCIS cases. They range anywhere from 14 to 26%. And this is for all cases of DCIS, ER-positive and ER-negative. There are very few studies that have exclusively looked at the ER-negative DCIS cases. So the objective of this study was to determine tumor upgrade rates for estrogen receptor negative DCIS compared to estrogen receptor positive disease. Secondly, we wanted to compare the impact of surgical delay on outcomes of patients with ER-negative DCIS that was upgraded to invasive disease. We performed a retrospective study of an observational database, the National Cancer Database. We examined data from 2004 to 2017. This is pre-pandemic. Tumor upgrade cases were classified by looking at the clinical stage and the pathologic stage in the NCDB. They had to be coded as clinical TIS, non-invasive disease, and pathologic T1 or invasive disease. We examined the following variables: the time from biopsy to first surgical procedure, broken down into less than 30 days, 31 to 60 days, and greater than 60 days, patient factors of age, race, and insurance status, and facility factors of volume and type. We looked at trends and rates of tumor upgrade for ER-negative and ER-positive disease. We looked at independent factors associated with tumor upgrade, adjusting for tumor, patient, facility factors, and the surgical delay. And we conducted a multivariable Cox proportional hazard regression model to assess overall survival for ER-negative DCIS cases that were upgraded to invasive disease. We had a median follow-up of 5 years. This is our strobe diagram showing the patient selection. We included patients who were female, patients who are greater than 40, and this is an NCDB rule that they do not include patients of younger ages to protect the privacy of the institutions, patients who had ductal histology, patients whose surgery was performed at the reporting facility. We excluded those patients that did not have a known ER status, or we did not have the clinical or the pathologic stage, lobular histology so that we could exclude LCIS cases, and any patients who had received neoadjuvant therapy. Our final cohort was 219,731 patients. We had approximately 184,000 patients with ER-positive disease and 35,000 patients with ER-negative disease. This is the demographic characteristics of the cohort. The median age was 60. We had predominantly white patients. The annual facility volume, 52% were of high volume, greater than 250 breast cases a year. Approximately a third were academic or research teaching institutions. The median time from biopsy to first surgical procedure was approximately 33 days. And we can see that approximately 35% of patients fell within a 30-day or 31 to 60-day time frame for their surgical procedure. About 11.7% fell outside of 60 days. This graph shows the trends in tumor upgrade rates from 2004 to 2017. Overall, the upgrade rates were higher for estrogen receptor negative DCIS cases at 16.2%. For ER-positive cases, the rate was 10.1%. We can see here that for all patients, the blue line went from 9.3% to 12.3%. For patients with ER-positive disease, the upgrade rates went from 8.4% to 11.1%. For those with ER-negative disease, the blue line, we see an upgrade rate from 12.9 up to 18.9%. This table lists the factors associated with tumor upgrade for both estrogen receptor negative and estrogen receptor positive disease. And we see changes between ER negative and ER positive disease by patient age, race, facility type, and the time to first surgical procedure. As patients get older, the rate of tumor upgrade does go down. And that's more marked for patients with estrogen receptor negative disease than estrogen receptor positive disease. A notable finding here for race, we see that African Americans are 1.31 times more likely to have a tumor upgrade if they have ER negative disease, but we do not see that same association for ER positive disease. Similarly, we do see a little higher upgrade rates for Hispanics and Asians for ER negative disease compared to whites. But these trends pretty much persist, are the same for ER-positive disease. For facility type, we see that most of the facilities have a lower upgrade rate than an academic or teaching facility. And for biopsy to first surgical procedure, we do see higher rates of tumor upgrade as you get further out from your biopsy for both ER-negative and ER-positive disease. These are tumor factors associated with patients who had ER-negative DCIS that were upgraded to invasive disease. For the most part, there is not any major change in any of these tumor factors between less than 30 days, 31 to 60 days, or greater than 60 days. I will note here that approximately 40% of patients ended up with triple-negative breast cancers. 56% ended up with ER-PR-negative, HER2/neu positive cancers. Many patients had grade 3 disease. 40% of patients had tumors under a centimeter, and approximately 84% had negative lymph nodes. This is a multivariable Cox proportional hazard regression model looking at overall survival. And if we focus down here on the time from biopsy to first surgical procedure, we see that there is no significant difference in survival between 31 to 60 days or greater than 60 days. And this is for patients with ER-negative disease that were upgraded to invasive cancer. In summary, ER-negative DCIS has a higher tumor upgrade rate than ER-positive DCIS. Tumor upgrade rates have been increasing over the past decade for both ER-negative and ER-positive disease. African American race was associated with a higher upgrade rate for ER-negative DCIS than ER-positive DCIS, despite adjusting for all the different factors. And delays of greater than 30 days or greater than 60 days did not impact overall survival for those patients with ER-negative disease that was upgraded to invasive disease. There are several limitations. We do not have any imaging data in the NCDB. and we do not have any data on how patients presented. For example, did they present with a mass or nipple discharge? Only approximately 11% of our patients had delays greater than 60 days. And I mention this because we have another study where we're looking at the pathologic outcomes of patients who did have delay in their breast cancer surgery during the COVID pandemic. And the median number of days that we saw for our DCIS patients was 85 days. We do not have any information on disease-specific survival in the NCDB. We only have overall survival. In conclusion, surgical delays for ER-negative upgraded DCIS did not impact overall survival, but we do not have lots of data on longer delays. Reasons for increased trends in tumor upgrade rates is unknown, but these may have implications for future studies that examine observation of DCIS, particularly ER-positive DCIS. Thank you.
Our invited discussant is Dr. Janie Grumley from Providence St. John's Health Center.
Thank you so much to the Western Surgical Association for allowing me to discuss this very important paper, and thank you, Dr. Yao, for getting me the manuscript at a timely fashion so I could review it thoroughly. As we all know, ductal carcinoma in situ is a heterogeneous group of diseases, and prediction of molecular behavior will allow for better individualization of treatment. As we all know, taking care of patients with ductal carcinoma in situ, they want to have surgery yesterday, but it cannot always be possible, and we usually reassure them that waiting is not an issue. So this question about timing is truly very important, and looking at whether or not that does impact our upgrade rate to invasive disease. Now, this is a retrospective study that looks at this important trend in upgrade, but the authors do predict that surgery time may impact the upgrade rate in ductal carcinoma in situ. As we know, most imaging centers are not created equal. Highly skilled radiologists and pathologists can make a very big difference in the diagnosis, in the accurate diagnosis of breast pathology. Could this trend in the upgrade rate and delayed surgery really a reflection of the inequalities in care? As you know, the NCDB does not indicate where the biopsy was actually performed in the high volume centers versus low volume community centers and the pathologists that provide those diagnoses. Perhaps a delay in surgery is really a result of being diagnosed in a community center and then sent to a specialized center for care. There have been numerous studies that have supported the notion that expertise in this pathology does increase our accuracy. So do you think that if we operated on ER-negative DCIS within the 30 days of diagnosis, we could actually reduce this upgrade rate? Or could it be that time to operation is really just a surrogate for the quality and the access of care? My second question for you is 40% of the patients that upgraded to invasive disease had lesions greater than 1 centimeter. In the age of advanced diagnostics, I find it surprising that this was not detected prior to surgery. Do you think that the 30 days made the difference, or perhaps this is an inconsistency in our preoperative workup of our patients? And my last question for you is that since there is no difference in survival, do you feel that operating on patients before the 30 days will impact the actual treatments for these patients? Thank you.
Thank you very much for your comments. I completely agree that time to surgery may be a surrogate of access to care, and may be a surrogate of many things. As you know, we do not have any imaging data in the NCDB. We don't know how these patients presented, and factors like whether a mass was present on exam, whether there was a large area of calcifications, a multicentric area of calcifications, the type of needle biopsy that was performed, all of these factors have been shown repeatedly in previous studies to be associated with tumor upgrade, and they're unfortunately not factors that we can account for in this study. And I think if we were able to study some of those factors, we might have more answers to questions of why we're seeing these tumor upgrade rates increasing through the years, why we're seeing higher upgrade rates at some of the academic centers, and just giving us some more answers to those questions. I would say at the academic medical centers, it may be pathology expertise that may account for some of the higher upgrade rates, but we do see that the time to get overall care tends to be a little higher at the academic centers. and I wonder whether that plays a role too. Your second question about the tumor size of patients with ER-negative DCIS that were upgraded to invasive cancer, it is true that approximately 60% were listed as greater than a centimeter, but there were about 20% of patients overall that had unknown tumor size. So when you take those patients out, we technically have 20% of patients that have tumors greater than a centimeter. Your third question about operating on patients within 30 days, will that make a difference? It's difficult to say. I wonder whether this time from biopsy to first surgical procedure is, just like you mentioned, a surrogate for other factors in the patient's care plan. And like I mentioned previously with another paper that was presented yesterday, we focus so much on the time from surgery, from biopsy to surgery, but there's so many other things that happen prior to that biopsy. When did the patient come in and get their screening mammogram? When did they get the biopsy done? There are just so many different factors that I'm not convinced that the time from biopsy to surgery is the only thing that we should be focusing on.
Dr. Hansen?
Great, Nora Hansen from Northwestern. Great paper, Kathy, and very timely with all the COVID that we had to deal with. And I know you and I have spent hours talking to patients trying to sort of allay their fear that the delay in surgery is not going to change outcome. And I think, you know, the fact that you've shown that the timing of surgery doesn't really matter is a good thing. In terms, and I think it may be partly have been asked already, but in terms of those patients with the ER-negative DCIS who were upgraded, how many would you can you say their treatment really changed? I mean, for those patients, did their need for chemotherapy increase? I guess if you said, and I missed it in the talk, there was a group that had greater than a centimeter, so they would have gotten chemotherapy. But I guess many times if you start chemotherapy in a certain time, it's not going to change outcome anyway. So do you have any more data on terms of how many patients really had their treatment changed? And do you think that the delay was detrimental for them in terms of getting chemotherapy? Thanks.
Yeah, I think you bring up a very good point, and this is something we need to look into further, that you find when you take care of breast cancer patients, survival and recurrence are important endpoints, but there are certainly lots of other patient-reported outcomes that patients value very much, maybe more so than the recurrence and survival, such as quality of life. And I think if you tell a patient who has ER-negative DCIS that if we wait to do your surgery over this certain amount of period, and you end up with an invasive cancer, you're definitely going to get chemotherapy, as opposed to if I do your surgery within 2 weeks and you're upgraded, you won't get chemotherapy, you can guess what most patients will want. So I think that's definitely something we will have to look at.
Dr. Godellis?
Just a quick comment. Dean Godellis, Loyola Chicago. So we sit here and listen about all these NCDB studies, and we always say that there's limitations. But being someone that's very involved with the NCDB, Kathy, is there a way that we can look back at some of these things and maybe put some of these data points that we want into the stuff that's captured so that we don't have these discussions on a regular basis?
So there is an ongoing effort right now in the college being led by Heidi Nelson to revamp some of the factors and variables that are in the NCDB. And in a concerted effort to include recurrence data so that we can look at disease-specific survival, looking at imaging data, genetic information. It is extremely, extremely complicated. As you can imagine, you're dealing with tumor registrars, coding books, Ford's manuals, but there is a concerted effort right now to really revamp what we're looking at, and maybe even removing variables that we don't really use. The registrars are extremely overloaded right now. It's impossible to find a tumor registrar, so we have to be very careful of that as well.
Well, Dr. Yao, thank you for an outstanding paper, and also thank you for your outstanding work on chairing the membership committee this year for the Western, and done a great job of increasing our membership. We finished on time. Thank you, Kathy.